Hi, everybody. My name is Sage Lewis. I'm your host today, and today I'm with Trisha Marcell, a registered nurse and orthopedic patient navigator. And today, Trish is going to talk about how to prepare for your surgery, what to expect after the surgery, and even beyond. So, this is a great way to prepare and know what is going to be happening. So, without further ado, take it away, Trish.
Thanks, Sage. Hi, I'm Trish Marcell. I'm going to be going over what to expect when you're having your total hip or your total knee replaced at St. John Medical Center. So I'm going to pull up a PowerPoint screen, kind of walk you through the expectations. So I'm going to go ahead and share my screen real quick. Okay, so this is the PowerPoint that I use in the in-class meetings, in-person meetings, I should say. So we're just going to go through these slides. First slide is a picture of the hospital. So that's St. John Medical Center. And here we go. So the goal of the class to get you prepared for the total joint experience. The more you know before, the easier it's going to be for you after. So there's going to be a lot of information in this presentation, but when you're going through the process, it'll all make sense. Everything will just kind of fall into place. Your coach, your care partner, the person that's going to be helping you throughout your recovery is going to have an important role throughout this process as well. No, a coach doesn't have to be with you 24/7 when you leave the hospital, but a coach will have to help you pick up your prescriptions from the pharmacy because you won't be able to drive. Maybe the first time you go up and down the steps when you get home, just having your coach there to help supervise is probably a good idea. So they do have an important role, but you're going to be very independent when you go home. So just having a coach around to be your support is a good idea. But they don't have to be, get you bathed and dressed and all that stuff. You'll be able to do that on your own. This is what we're going to talk about today. So like I said, a lot of information. We'll talk about our unit we have at St. John. We'll talk about why you're having surgery, how to prepare, of course, what to expect after. Also, we'll talk about the therapy portion of the process, discharge planning, where you go once you leave the hospital and how that's set up for you. Of course, what to pack for the hospital and preparing your home for your return and some recovery stuff as well. So like I said, a lot of information, but we'll get it covered from start to finish. So a little bit about our unit that we have at St. John Medical Center. Our unit is called the Spine Orthopedic and Surgical Center. We have 26 private rooms on our unit for our orthopedic patients. And we do have our own therapy gym on our unit. So therapy sessions aren't held necessarily in your room. A therapist will walk you down to a gym-like setting where we have a mat table, we have weighted arm bars, we do have a practice set of steps in there, a practice bathroom. So we can kind of simulate what you need at home in our therapy gym, which is nice. We do have Wi-Fi access in the hospital. So if you'd like to bring your cell phone, tablet, laptop, all those devices are permitted to be used and you will have internet access. You do not have to bring in a device though. You will have a landline phone in your room where you can make local phone calls. Also, the phone in your room is used to call for room service. We use room service at St. John, so you can you get a very large menu. You can pick exactly what you like to eat, call down, and they will bring it to you in about 30 to 45 minutes. So I'm sure your surgeon spoke to you about why you're having surgery, but this slide just goes over trying to understand why the hip or the knee needs to be replaced, because that arthritic or damaged joint in your knee or your hip is interfering with your life, causing you pain, discomfort. So that artificial joint that's placed in there is going to be designed to move like your healthy joint again. And we'll kind of go over the anatomy of the hip and the knee, and then it'll make sense. And again, joint replacement is to help get rid of that pain that's interfering with your daily activities and sometimes even still work. So that is the goal. So we'll first start talking about a knee replacement, what makes up the anatomy of the knee. We have this long bone that runs up the top portion of our leg called our femur bone, and then two bones that run down the bottom portion of your leg, the main one being your tibia or your shin bone. On the ends of those bones where they meet in that knee space, there used to be nice smooth cartilage on the ends of those bones. So when you moved your knee, it was a nice smooth surface. Well, when osteoarthritis sets in, that smooth cartilage actually starts crumbling away. So when you move your knee, bone could be exposed to bone, and that's what's causing that pain, that discomfort. So those ends of those bones have to be replaced with a smooth prosthesis. So when you move your knee, it's a nice gliding surface. So you'll see a normal knee x-ray on the screen here. The two bones, that femur bone, that tibia bone, you see the nice space between those bones. That smooth cartilage is still intact. And then an arthritic knee x-ray where you have the one side where it's bone on bone because the smooth cartilage has worn away. In the little cartoon picture in the corner, you can kind of see how that smooth cartilage kind of crumbles away in patches. So you can imagine that when you bend your knee, that's uncomfortable, painful. So those pieces and parts are replaced, so you have a smooth surface, so your knee moves like a healthy joint again. I'll show you what the pieces and parts look like on the next page. So you can see these are the components of a knee replacement. So there's 4 different components placed in the knee to replace those damaged parts. You can see that some of them are a metal component. So after your knee is replaced, when you have an x-ray, they will illuminate on an x-ray. And you may set off the scanner in the airport, things like that because of those metal components. So for the hip surgery, a very different joint. A hip is a ball and socket joint, but still made up of that femur bone, that long bone in the top portion of your leg. And actually on the end of that femur bone is actually a head and a neck. So the head of that femur bone sits in the socket of your pelvis, but still same. The head of the femur, socket of the pelvis is lined with smooth cartilage. So that's what starts crumbling away with the osteoarthritis. So when you move your hip, bone could be exposed to bone, causing pain and discomfort. So you'll see a normal hip x-ray between the head of the femur, socket of the pelvis, there is a space, and then an arthritic hip where the bones, on the bone, essentially, the smooth cartilage has worn away. So again, those pieces and parts have to be replaced. So you have a nice smooth surface in there again. So I'll show you what the pieces and parts look like on the next page. So the head of the femur is now going to have a metal head with a stem in the femur bone. Socket of the pelvis has a cup with a shell inner lining that goes in there. So when that metal head sits in that socket and moves, it's a smooth surface for it to rotate in. So no more bone on bone pain. You know, a lot of pain with the hip that needs to be replaced is in the groin and in the buttocks. So when that smooth metal head is, that bone is replaced with that smooth metal head, when that rotates in that shell, it's a smooth surface. There's no bone on bone, no groin, no buttocks pain anymore. And of course, some of those components are metal. So you will see them illuminate on an x-ray. So in actual preparation for surgery, hip or knee, everyone's going to go through the same sort of preparation or pre-admission testing. So this slide just kind of goes over how preparation begins weeks before surgery. Some surgeons require a clearance from your primary care doctor. If you see any sort of specialists, you may have to do additional tests before your surgery. If you have any dental issues, it's advisable to see your dentist before you have joint replacement. And of course, just exercise, doing the exercise packets. You know, if you smoke, quitting smoking, and stop taking certain medications. All that will be discussed with your doctors in preparation for surgery. Pre-admission testing usually scheduled about 1 to 2 weeks before surgery, and all pre-admission testing is a list of tests that your surgeon has sent in that he wants you to complete before your actual surgery date. So sometimes pre-admission testing is done at St. John, all of it. We have a department at St. John on the first floor, or some of your doctor's offices may do parts of the pre-admission testing. It doesn't matter where pre-admission testing is completed as long as all those tests are complete. So you can expect a physical exam by your physician or our nurse practitioner at St. John, blood tests. If you see a cardiologist or any specialist, you may have to do an EKG or chest x-ray, something like that may be required. Also, they're going to do a MRSA test or MRSA test which is a methicillin-resistant Staph aureus. I'm sure you've all heard of MRSA, where it's a nasal swab test to test if you're a carrier of MRSA. If you are, we will contact you and have you pick up a special ointment that you have to put in your nose. So if you get the test done, you don't hear from us, your test was negative. If you are a carrier, we will call you to pick up the ointment. It's also a good idea to bring a complete list of your medications with you to pre-admission testing, and even prepare a list to bring with you when you come to the hospital. It's not necessary to bring your medications in with you. We don't want to lose your pill bottles, but use your pill bottles at home to get the exact name, dose, how often you take the medications, and put them on an accurate list to bring with you, so we can get those in the computer system. And then after your surgery, your surgeon will tell us what medications he wants you to take while you're in the hospital. It may not be every single thing on your list, but it's important to put everything, not only prescription medications, but any non-prescription medications or vitamins, supplements, herbals that you may take. It's a good idea to put all those on the list. There's a picture of our pre-admission department at St. John, which is on the first floor. Also, at your pre-admission appointment, you're probably going to hear about how you have to stop taking any NSAIDs 1 week before surgery. NSAIDs would include ibuprofen, Aleve, Advil, things like that have some blood thinning properties to them. You'll have to stop those 1 week before. Also, there's some herbals, dietary supplements, and some vitamins they want you to stop 7 days before. That's why it's important to bring in a list so we can kind of go over which ones will need to be stopped before surgery. Of course, if you take any blood thinning medications such as aspirin, Plavix, Eliquis, or Coumadin, those obviously are going to need to be stopped before surgery as well. It is fine to take Tylenol for pain or acetaminophen. That will not thin the blood. So Tylenol is fine to take before surgery. Also, in preparation for surgery, they're going to want you to shower with this special soap the night before your surgery and the actual day of your surgery. This preoperative soap is given out in pre-admission testing. So when you come to the hospital for pre-admission testing, they will give you a bottle of this soap and a handout on how to use it. Also, they recommend a bowel cleanse. Whatever works best for you, take something to help move your bowels before surgery. We're going to give you medications during surgery and after that slows everything down in the system. So you're gonna, it's gonna be a few days before you move your bowels. So it's better to cleanse the bowels before you come in, because if you don't go 3 days before and then now it's 3 or 4 days after, we're going to be in trouble. So whatever works best for you over the counter. It doesn't have to be like you're having a colonoscopy and you need to go lightly, just something gentle in the stomach over the counter. I'm sure you've all heard nothing to eat or drink after midnight unless your surgeon has specified otherwise. Some surgeons will have you take a little bit of fluid but on the day of your surgery, which is perfectly fine. Just let us know what you did take when you come to the hospital. And that holds true for any medications that your doctor wants you to take with a small sip of water on the day of your surgery. If they told you to take it, it's perfectly fine. Just let us know what you did take when you come in to the hospital. You'll receive a call stating what time your surgery will start, and you will have to arrive to the hospital 1.5 to 2 hours before that surgery time. The easiest place to enter the hospital is through our outpatient surgery entrance, which is back by our emergency room. You won't miss it. If you pull around the backside of the hospital, you'll see our emergency room entrance and then an awning that says outpatient entrance. That is the easiest place to enter. When you enter the hospital there, and there is a visitor's parking lot back there. So whoever brings you can drop you off, park in that lot, and come in with you. So when you enter the hospital, you'll see this spiral staircase on the left-hand side. I have a picture on it of this on the next page. The elevator is located underneath that stairwell. That elevator underneath that stairwell only goes to the second floor for surgery check-in. So if you find the elevator, it's going to take you where you need to go. I wouldn't bring any valuables into the hospital with you. You'll need to bring your insurance card and your ID. And of course, that list of medications, but you won't need credit cards, cash, expensive jewelry. I would leave all that at home or with your loved one, just your insurance card, your ID, and your list of medications. So when you take the elevator to the second floor, when you get out of the elevator, there is a check-in desk. You're going to check in and sit there in the waiting area until they call you back for surgery. When they call you back for surgery, they're going to have you get dressed in a hospital gown, take your vital signs, just kind of go over the information that they receive from pre-admission testing, go over your drug allergies, things like that. In that room, that is also where the anesthesiologist or someone from the anesthesia team will meet you, and they'll go over what they're going to do for you during surgery and have you sign a consent form. So if you wear glasses or wear hearing aids, I would make sure you have those with you so you can read and sign the forms in that room. Also in that room, your surgeon will come in and he will take a skin marker and he will mark on your knee or your hip, whatever side, whatever joint you're having surgery on. Everyone does it. They take a little marker and mark on the joint before you go into the operating room. Also, your IV will be started in that room as well. So all they're really waiting for at this point is the operating room to be ready. So once the operating room is ready, they're going to wheel you into the operating room. Surgery takes approximately 1 to 2 hours, maybe even a little less than that. And if your family wants to speak with the surgeon, they have to wait there on that second floor waiting room, and he will come out and speak with them when he is finished. At this point in time, your family is more than welcome to go home, let the dog out, go take a nap, go have lunch, or even come up to your room if that's ready on the 4th floor, because it's going to be a while. Once you're out of the operating room, you will go to a recovery room. And recovery room times can vary from 1 to 3 hours. So it makes for a long day. It's your family's waiting. So if they need to run home or whatever, they're more than welcome to do that. As a patient, you go to the recovery room. And like I said, it's a closely monitored unit. They'll be watching your vital signs. If you're having pain, start giving you pain medications, things like that. So the recovery room, there's no visitors allowed back there. It's, like I said, a closely monitored unit, and it can last anywhere from 1 to 3 hours in that unit. Once you meet the criteria that you're stable to be moved to the 4th floor, they will call, make sure your room is ready, and bring you on up. So everything from where you check in the morning all the way through to the recovery room is on the 2nd floor of St. John. You won't be brought up to the 4th floor until all that has been completed. So when you're wheeled up to the 4th floor, you will already be on the bed that belongs into your room. So you'll be wheeled up, and that's the secretary's desk that you will see when you come on to the orthopedic unit. When you're placed in your room, you'll be greeted by our staff. We'll come in, family members, if you're up on the unit, we'll ask you just to step out for a moment. It's just easier. We get in, get our questions, get the patient settled, and then you'll go in, be able to go in and visit. So when you come up to the unit, we'll place you in your room. Their nurse will ask you questions, kind of get you settled, and kind of go over everything that's kind of hooked to you or around you. So you will initially have some equipment with you. That IV that was placed in the morning will still be connected to a tube hydrating you with fluids through your veins initially. Once you're eating and drinking, that IV will be disconnected. You might have this thin plastic tube in your nose, around your ears, administering oxygen. Once your oxygen levels are okay, the oxygen will get taken away. You may or you may not have a catheter in your bladder. If you do have a catheter, we will remove the catheter the next morning. It does not stay in longer than 24 hours. And if you don't have a catheter, we obviously will tell you, and then you will call us and we will assist you to the bathroom. You will also have these compression devices on your legs. They wrap around your calves and kind of squeeze and release to help with blood flow, circulation, help prevent blood clots. We try to keep those devices on your legs anytime you're in the bed in the hospital or even up in the chair. They extend over to the chair to help prevent blood clots. You will obviously have a bandage on your incision, which we will go into detail with on the next slide. The nurse will go over the incentive spirometer, which is this little deep breathing machine, and encourage ankle pumps. And of course, we will assist you out of bed to a chair or sit at the side of the bed, with the goal being on the day of your surgery to do that. So if you're having your hip replaced, you obviously will have a bandage over your incision. Whatever bandage you start with, the bandages we use when we send patients home are a waterproof bandage that are good for 7 days. So patients are allowed to shower when they go home. The only other piece of equipment you may see with a hip replacement is an abductor pillow. It's this purple foam wedge that we place in between your legs to help remind you not to cross your legs, which could be one of the restrictions with the hip replacement, which we'll talk about when we talk about therapy. But that would really be it. There's no sort of drain or anything. So you start with the bandage. You may have an abductor pillow. And then when we change the bandage or when we send you home, we will give you specific instructions on how to care for your incision. With the knee replacement, the bandage is a little different, obviously. The bandage starts up in the groin and it's wrapped all the way down to your toes. It's an elastic ACE bandage. So it stretches. You can bend and straighten the leg with this bandage on. And it's wrapped all the way down to help with swelling. There is a lot of padding and gauze underneath that ACE bandage. So it may look a little more swollen than it really is. You may or you may not have a drain coming from the knee site. That drain is temporary. It will be removed the next morning, but you may start with a drain. So as soon as the surgeon gives us the okay, we'll cut that entire bandage off. And your incision is not from your groin to your toe. It's right over top of your knee. And they'll tell us specifically how they want us to care for the incision. And then we will educate you on that. Some surgeons just want the incision left open to the air because they use the special glue. And again, that glue is waterproof and we'll tell you how to care for it when you go home. Or they may have us cut off that ACE bandage and put a waterproof bandage over the incision. Again, you'll be able to shower when you go home and we will instruct you exactly how to take care of that incision and when to change the bandage, things like that. So you do start out with some equipment, some bandages, but every hour that you're in the hospital, every day that you're in the hospital, things get slowly starting to take away. So when you're up moving with therapy, you're not necessarily have a bunch of equipment with you. Probably the most important topic of the class, I think, is pain management, because we want you to get up and move and exercise and do all these things. And it's really hard to do when you have pain. And I'm not going to sugarcoat anything. There is going to be pain after surgery, but what are we going to do to manage it? Because if we can manage it in the hospital, we know that you can manage it at home as well. So that's important. So you can get the therapy in and be successful with these surgeries. I'm sure you've all heard of the pain scale. We use the pain scale, the 0 to 10 pain scale. So you'll be asked that multiple times while you're in the hospital. But we really are just trying to get a hold of if the pain medication the surgeon has ordered for you is working. So we want to make sure that's working while you're in the hospital, because that is the medication they send you home with. Our pain medications in the hospital are ordered on an as needed basis. which means that it's not a timed medication that comes in every 2, 3, 4 hours. You have to ask for it or request it. And our nurses will help you. They'll coach you through this process, even letting you know if they give you a pain medication the next time that you can have it. So you can hit your call light if you need additional pain medication. So it's not, so it's on an as needed basis. The pain that you have after surgery is described more as a surgical pain. So this pain should start decreasing over time and be controlled with pain medication. Typically at St. John, after surgery, the surgeons will order an IV pain medication and a pill form of pain medication. IV pain medications are typically used right after surgery because patients don't have any food in their stomach. It's hard to introduce pain pills on an empty stomach. So typically we start with IV pain medication. Once patients are eating, we will switch that over to pill form of pain medication. Both medications are ordered on an as needed basis. The pain medication they give the patients by mouth or the pain pills are the same pain pills that they order patients when they go home. So that's why it's important to communicate if the pain medication is working, so we can make sure when we send you home with that same medication, it's going to do what it was doing in the hospital. So we do use narcotic pain medications. There's also non-narcotic medications for patients that are real sensitive to narcotics. So the surgeons do a really nice job in finding a good combination of what's going to work for you, because every patient's a little different on what they need for pain control. Of course, non-medication interventions are very useful, such as ice. Putting an ice pack on the hip or the knee after surgery works wonders. We use ice packs in the hospital, and then we will encourage you to use ice packs when you go home as well. Even positioning, getting up and moving, sometimes just moving the joint, sometimes it'll feel a little stiff, will help with pain. Total knee replacement patients are candidates for a nerve block. Maybe you've heard of this before, maybe not, but nerve block injections are given after surgery in the recovery room. It's something that the anesthesiologist will do. And what it is a syringe of numbing medication that the anesthesiologist will place on the femoral nerve, which runs down the front part of your leg. So numbing medication on the nerve to help with pain control in the front part of your leg. It does not last forever though. 12 to 48 hours maybe, but it does help initially with pain control. You'll see this red stop sign in your rooms in the hospital. It's just our way of telling you, make sure you call us. Your safety is the most important. So we want to assist you when you get up to the chair or to use the bathroom, or if you need to get something out of your closet or your nightstand or sit up on the side of the bed. We're here for you. So all you have to do is call us. We want to keep you safe when you're in the hospital. So of course, therapy is very important after a total hip or a total knee replacement. And you are the most important person in your rehab and in your recovery. Of course, we encourage coaches and caregivers to be in the hospital when you see a therapist, so they can kind of see the exercises and things to expect when you go home and when you're discharged from the hospital. Our goal in therapy is to get you up on the day of your surgery. If it's not with a therapist, the nurses are all trained to get patients up, but the goal being on the day of your surgery to get you up and get you moving. You will definitely be seen by a therapist. If you're not seen the day of your surgery, the next morning a therapist will see you for your evaluation. So therapy goals while you're in the hospital, obviously in and out of bed, on and off the toilet, up and down from a chair, and just walking on level surfaces, and of course stairs. So they go over a variety of things in physical therapy. and also occupational therapy while you're in the hospital. For patients having hip replacement, if you have any sort of hip precautions after your surgery, your surgeon will tell us those specific precautions, and the therapist will start training you on those while you're in the hospital. So we'll discuss some things that you may see if you're having a hip replacement and how you can still be independent and do your activities of daily living independently, but you may have to modify those or use special equipment to protect the hip. For a total knee replacement, one of the therapy goals is just getting range of motion and increasing that range of motion over time. We try to get your leg or your knee bent to at least 90 degrees before you leave the hospital. And then throughout your course of therapy in the hospital and beyond, just trying to get increasing that range of motion. Because having that range of motion, especially at 90 degrees, you're able to get in and out of the bed, on and off the toilet, up and down the stairs, in and out of your car, things like that. So that's why range of motion is so important with the knees. Of course, with the hips, range of motion is important, but again, if you have any sort of hip precautions, and since the hip is a ball and socket joint, it's important, and the therapist will teach you that you want to make sure you don't push your hip past that safe comfort point and that risk of dislocation. So again, therapists will teach you in the hospital and beyond how to protect that hip. Of course, muscle strength is a therapy goal, just gaining muscle strength in that quad, especially with the knees. So a lot of exercises centered around that. And then with the hips, this muscle strength will be gradual with those exercises and things that they teach you after surgery. We do have an exercise handout. So if you want to familiarize yourself with these exercises and you need a copy of those, of course, you can always reach out to me. I can email them, send them in the mail, whatever you like. Just the more strength and endurance that you can get before surgery, the easier it will be for you after. And a lot of the pre-operative exercises that you see before, a lot of those exercises are the same after. So the more familiar you are, the easier it will be for you. So also in therapy, just doing a lot of transfers in and out of bed, on and off the toilet, up and down from a chair. They'll be going over and over this with you. And any sort of hip dislocation precautions, we'll start practicing those while you're in the hospital. Of course, you'll be encouraged to get up and move and sit up in the chair as much as possible when you're in the hospital. So when you get up and walk with therapists for the first time, you'll be using a two-wheeled walker. And when you get up for the first time, you may feel lightheaded, you may feel nauseous. This is very common. Just let the therapist or the nurse know when you're feeling that way, and then we will adjust the therapy. Like I said, everyone will be using a two-wheeled walker to start off with. And then as you go through the process of therapy, you'll be trained on a cane and then no assistive device at all. We will practice stairs before you go home from the hospital. So if you have stairs to negotiate at home, we will definitely start training you on that. So you'll be able to go up and down the stairs when you get home. So these are some of the hip dislocation precautions that you may see if you have your hip replaced. Not all of these precautions apply to every hip replacement, but these are some that you may see. And again, the therapist will go over any specific precautions that your surgeon wants you to do after surgery. And these precautions don't last forever. Maybe 2-3 weeks until everything's healed up, and then you can go back to doing these things once you're cleared by your surgeon. So you can see some of those precautions listed on the page here, but on the next few slides, you'll kind of see some pictures that go along with these precautions. They may not want you to bend beyond 90 degrees. So if you have to pick stuff off the floor or, to put your socks and shoes on, you may have to use different tools and gadgets to be able to do that. So you're independent with getting yourself bathed and dressed. Another precaution is, not to bend beyond 90 degrees. So sitting on a couch, a low chair, low toilet seat where your knee is higher than your hip. Some surgeons may not want you to do that with your brand new hip. So modifying your chairs to make them elevated, or your toilet seat elevated, or, your favorite place to sit on the couch, getting a nice firm surface for you to sit on so your knee doesn't come higher than your hip. Again, raising your knee higher than your hip, going past that 90-degree angle. Also doing that sort of motion. They may not want you to do that after your hip's replaced. Pushing it kind of past its comfort zone, past its resistance. Sitting on a low surface, like I said, low couch, low toilet. Rolling your leg inward. You always want to try to keep your toes pointed the same way. So the leg kind of wants to naturally roll inward. So putting something in between your legs to keep your toes pointed up. And again, the therapist kind of go over these with you as well. Or crossing your legs. Your surgeon may not want you to cross your legs. So if you're a leg crosser, you may want to use pillows or something in between your legs to kind of prevent you from crossing them. Also, crossing your leg across the midline could be one of your precautions that you have after a hip replacement. An occupational therapist really goes over activities such as bathing, dressing, toileting, things like that. So an occupational therapist will see you in the hospital and kind of go over any modifications that you need to make for your activities of daily living, especially if you're having a hip replacement and you have any precautions, and also suggest any necessary equipment that you may need after hip or knee replacement. These are some of the equipment that you may see, some things they may recommend. If you've ever heard of these before, sock aids, reachers, long-handled sponges. That's what a two-wheeled walker looks like. That's what you start off with the two wheels in the front. Bedside commodes, elevated toilet seats. So that's just kind of a look at what kind of equipment that they may suggest after your surgery. Of course, a big part of having total hip and total knee replacement is the discharge plan. So when a therapist sees you in the hospital, they do what's called an evaluation. And what that entails is they will ask you questions about your home setup, who's home with you, watch you physically move, get in and out of the bed and walk with the walker, things like that. And then they make a recommendation on where you should go once you leave the hospital. 95% of our patients go directly home from the hospital. So that is the ultimate goal for everyone. But we have to do an evaluation to make sure that's the safest discharge plan. So therapy plays a big role in the discharge plan. And then it's kind of a collaboration with therapy, your surgeon, case management to kind of get you to your next destination safely. Of course, your safety is first and foremost to everyone. And again, they ask you a lot of questions about your support in the home. Whether you're having the hip or the knee is a factor that comes into play in your evaluation, insurance coverage, and the recommendations from your therapist and your surgeon. So these are some of the things that they could recommend upon discharge. The first one is home with outpatient physical therapy. This means that you're in the hospital, you go home, and then you go to an outpatient physical therapy center for therapy 2 to 3 times a week, depending on your insurance. The only issue with outpatient physical therapy right after the hospital is you're not able to drive yourself to therapy. So you would have to have a ride, which, a lot of patients will do, but a lot more patients would opt for the home with home health care. So they could suggest that. That means you're in the hospital, you go home from the hospital, and then a therapist comes to your house to provide therapy for you 2 to 3 times a week, depending on your insurance. Home health care sounds a little confusing because it's not, a nurse and nursing assistants coming into the home. It is a home health care agency that sends out a therapist to your house to work with you. So that's probably the number one destination for our patients. But also, whatever is the safest is what they're going to recommend. And if home is not the safest place for you, they may recommend a skilled nursing facility or an acute rehab, and we'll work with you and a case manager on those as well. So like I said, a physical therapist begins to talk to you about discharge at your first therapy session when they're doing their evaluation. And we want you to know that the plan can change if they recommend one thing. It's like an evaluation every time they see you, trying to progress towards the goals. So we try to keep you updated on the plan. A case manager or a social worker will also be involved with your discharge. So you will see them probably the day after your surgery. They'll come in, see what the recommendations are, and work with you to set up the next step in your discharge plan. So if it's outpatient therapy, making sure you have an outpatient center picked out and an appointment made. Also, if it's home health care, setting you up with a home health care agency, the case manager will make those calls, make sure they're covered by your insurance or in your network, and set you up with home health care. Home health care, the goal is for them to come see you in about 24 to 48 hours after you're discharged from the hospital. Also, getting equipment is part of the discharge plan. A lot of surgeons will already have set patients up with wheeled walkers and other equipment before you even come to the hospital. If you are not set up with a wheeled walker before you come to the hospital, we will arrange to get you a wheeled walker or any other equipment before you go home. Like I said, home health care will be set up for you to leave the hospital, with the goal being a therapist to come out and see you about 24 to 48 hours after your discharge. And of course, the frequency of your home care visit depends on your insurance. What to pack for the hospital. Like I said, when you first come to the hospital, it's not a good idea to bring a bunch of stuff with you. But if you want to pack a small bag and your loved one or your family member that's going to come see you in the hospital wants to bring in your bag once you get your room, that would be a good idea. Having a change of clothes. So once you're able to change out of your hospital gown, we can help you get dressed in your regular clothes. Anything that you like to work out in. Shirt, pants, shorts, yoga pants, pajama bottoms, whatever, works best for you is fine. Underwear, bra, socks, a good soled tennis shoe or loafer works best. Something that's, when you're up walking with the walker, your shoe doesn't fly off and cause you to trip up, something that holds your foot nice and firmly. So it's a good idea to have a change of clothes in that bag. Also you can bring in your own toiletries if you want. You don't have to. We have, toothbrush, toothpaste in the hospital, but if you prefer your own, totally understand. You can bring in your own. That's fine. Anything else that you like to pack in your bag, cell phone charger, things like that. Books, magazines, crossword puzzles are fine to pack in that bag as well. We will take an inventory of what you have brought into the hospital and make sure you leave with all those items when you're discharged. Like I said, 95% of our patients go home from the hospital. So we want to make sure that your home is ready for you when you return. It's a good idea to arrange for someone to stay with you the first few days that you are home. Make sure items are easily within reach. Of course, night lights throughout your home is helpful. Some patients will be able to hang a small bag on their walker or have pockets in their clothes. So when they need to get a snack or a drink or something, they're able to carry it. You want to remove any throw rugs or small items from the floor because you will be using a two-wheeled walker. So you want to make sure that you have a clear path to get to your kitchen, to your bathroom, to your favorite place to watch TV. So moving rugs or furniture out of the way to prevent any tripping hazards. Also, if you have small dogs or big dogs or cats, so when you first get home using your walker, you want to make sure you have a place to put them so they don't get excited and knock you down. If you're going to be home by yourself and you're looking at meal times or meal prepping, it's a good idea to do that ahead of time. Standing at your kitchen counter and trying to cook for 45 minutes is probably not going to happen. So having something easy that you can pop in the microwave or pop in the oven will be very beneficial for you. Of course, having handrails or on for the stairs or grab bars in the bathroom will be helpful. But again, when we work with you in therapy in the hospital, we ask you a lot of these questions and give you tips and things to do so you can be safe in your own home. There are some risks with these surgeries, and what are we going to do to prevent those? The first one being blood clots. Blood clots are a risk anytime you have orthopedic surgery. So we will use these compression devices on your legs during your hospital stay, but also the surgeon's going to put you on a blood thinning medication. The blood thinning medications anymore you're going to see is an aspirin tablet taken once to twice a day. We will give that to you in the hospital, and then the surgeon will instruct you on what to take when you go home and even provide you with a prescription if needed. Also, if you have history of blood clots or whatever the case might be, they may put you on an injectable blood thinner such as Lovenox, which again, we'll give you in the hospital and instruct you on how to give yourself an injection when you go home. Injections usually are about 5 to 7 days once you leave the hospital. Aspirin tablets are about 28 to 30 days once you leave the hospital. But to prevent blood clots, we will also instruct you on any signs and symptoms to look for when it comes to what would indicate a blood clot. Infection is always a risk. So before your surgery, you're going to get a dose of antibiotics and 2 doses of that antibiotic after. It doesn't mean you have an infection when we give you IV antibiotics. It's just in case. It's best practice to give you a dose before and 2 doses after. And of course, good hand washing to help prevent infection. 2 unfortunate complications are the nausea and the constipation. They kind of go hand in hand with the pain medication we give you. So if you become nauseous, obviously we want you to tell your nurse. We have medicine to help nausea, but we also have ginger ale and crackers 24/7. So if that helps settle your stomach, just let us know. It's important if you're taking pain pills that you have something in your stomach before you take those. Taking pain pills on an empty stomach usually equals nausea. Narcotic pain medications are very constipating, so don't be surprised if you're ordered a stool softener in the hospital, but you're definitely going to want to continue to take one when you go home. So something over the counter that you want to pick up, Colace, Docosate, Senecot, something like that. You're going to want to take that if you're taking narcotics at home. Also, for your recovery, it's important for hips to follow your precautions so we can protect your hip from dislocation. And for the knees, taking your pain medication, and that goes along with hips as well. Do your exercises twice a day. You may have some swelling associated with the hip or knee replacement. Using ice, keeping the legs elevated will help with that swelling. And of course, increase your activities gradually. Try not to sit too long. Every hour, hour and a half, even at home, get up and take a lap around your house just to kind of get the joint moving. Because a lot of patients will complain of joint stiffness. So getting up and moving will help with that stiffness. And as you increase your activities, of course, that will equal more leg swelling. So elevating your legs and keeping ice on your incision will help with that swelling. Also, no driving until you're cleared by your surgeon. That's probably one of the top questions patients will ask me. Every surgeon's a little different. Every patient heals at a different rate. Of course, if you're having your right knee or your right knee or your right hip replaced, it may be a little longer than if you're having your left. But I usually tell patients no driving until you see your surgeon at your follow-up visit, and they will give you clearance for that. We will go over some things to look for as well when you're discharged from the hospital. But of course, anything that would indicate an infection, we would want you to call the surgeon, or anything that would indicate a blood clot. And like I said, we go over the signs and symptoms of a blood clot. Unable to urinate or issues with constipation, or if you become short of breath. you're going to obviously want to call 911. So all these things we'll go over with you again at discharge from the hospital. Of course, taking good care of your total joint, and it will take care of you. So great, forms of exercise, walking, swimming, riding a bike, all low impact exercises are good for the total joint once it, your joint once it's replaced. So obviously, if you have any questions or concerns about the process or, what to expect, you can always reach out to me. Again, my name is Trisha Marcell. I'm the orthopedic patient navigator at St. John. There is my email address and also my direct phone number to call me with any questions or concerns. I will have to tell you, probably one of the first questions that I'm asked in the class is, how long will I be in the hospital? And on average, for a total hip or a total knee, you're looking at 1 to 2 nights in the hospital. There are patients that are candidates to go home on the same day of their surgery. So if you've heard that before, but typically that's a conversation that the patient has with the surgeon in advance before their actual surgery date. So they kind of are aware that they're going home on the same day. So the typical stay is 1 to 2 nights in the hospital. And that's the end of my presentation. So Sage, if you have any questions for me, or I can kind of go over top questions that patients typically ask me in the class, I can definitely do that.
That was amazing. I learned so much.
Thank you.
I had this paper and pen ready to go. Like, I'm going to I'm ready to ask all these questions. And then I got to it and I'm like, I don't have any questions. I guess, the pain thing, are people often, is that a big concern? Are people oftentimes worried about how much pain they're going to be in?
Yes, most definitely. And that's why I like to tell patients, there is going to be pain. So having that mindset before you even go into it kind of helps sometimes. We're going to do whatever we can to keep that pain under control and managed. That's why it's so important for patients just to communicate with us. If something doesn't work, we need to know. We don't have patients for very long. So if you talk about 1 to 2 nights in the hospital, we have to make sure we're on top of it and that pain is managed so patients can be comfortable when they go home. And that's one of the questions I wrote down too. Patients will ask me, well, how long will I be on pain medicine, or questions like that. And it really does vary. Every patient's a little different, but you definitely will see a decrease in pain medication usage as the days go on. So
are you the person they talk to? Like, say, okay, so they get home and the pain is getting really bad or something happens. Do they reach out to you first, or like who do they talk to?
So typically I tell the patients to reach out to the surgeon's office. If they're not getting through to them, obviously they can call me or email me anytime and I'll be able to help, assist with that. But since I'm unable to order pain medications, I usually just tell them to, try to contact the surgeon first, and then always use me as a resource if you can't get your questions answered or a response back, and I'll see what I can do to help.
And what about if people are really nervous about surgery? Like, how do you deal with the anxiety of leading up to the surgery?
That's a good question, because there are definitely, it's a big surgery. So, and some patients come into this and they've never had surgery before, so they're a little anxious, a little nervous. But I feel like if they have the information ahead of time, so coming to the class or listening to the class online, or even calling me with any questions or concerns, I think that takes away a lot of patients' anxieties. I may not be able to take all the anxieties away, but at least help a little bit. Just knowing what to expect sometimes helps.
Yeah. Well, what were some other questions that you normally get?
So, another question patients will sometimes ask me is, if I have a walker, should I bring it to the hospital with me? And the answer to that question is, it's not necessary. It's one less thing you have to worry about carrying to the hospital. We will have wheeled walkers for everyone to use. I typically will just tell patients to have the person that's picking them up from the hospital bring it in. We'll make sure it's sized correctly, or, at least we know they have it when they're getting in and out of the wheelchair, into the car and into the house. They have one available for them.
What about
Also, patients will ask me if they need to bring in their own medications. We don't advise patients to bring in their pill bottles. Just a complete list of your medications is fine. We don't want to lose your pills, so we tell patients to keep their pill bottles at home. What's another one I was thinking? I wrote some down. Oh, also, patients will ask, are they able to do the stairs when they go home? And we start stair training in the hospital. And, it's definitely feasible to believe that you could do the stairs when you go home. Going up and down the stairs 10 times in one day when you first get home, that's not going to happen. But, if your bedroom's on the second floor and you need to get up a flight of stairs to sleep in your bed and then get down those stairs in the morning to be on one level, that's definitely unreasonable to think that you can do that. But as time goes on, being able to go on up and down the stairs will get easier.
Yeah. What about like special dietary needs? Like, if people have special diets, is that?
Any sort of, you mean while they're in the hospital?
Yeah.
Yeah. So any special dietary needs, just please communicate that with us, as the nurses, or even your surgeon. And there's different diets that can be placed in the computer system to accommodate all sorts of diets anymore. So just let us know.
Oh, and I have a family member who's allergic to latex. Do you have a latex process? Like, is this a latex-free environment? Do you know?
Yes.
Okay.
It is a latex-free environment. So again, once you come into the hospital and they ask you allergies or at pre-admission testing, you're definitely going to want to mention that, and it's flagged on patients' charts if they have a latex allergy.
This is super helpful.
Well, thank you, Sage.
Well, of course. Thank you. Any other questions or thoughts?
No, I think I covered, everything. And of course, patients can reach out to me if something wasn't covered or they have a personal question. They can email me or give me a call, and I'll be able to assist them.
And you offer this in person, this class?
I do. The class is offered in person on Wednesdays at 10 a.m. at St. John on the 4th floor in our dining room of the Spine and Orthopedic Center. So we do offer in person. It does fill up fairly quickly, but that's why it's good to have an online version as well.
Yeah. Do you just call you to schedule, let people know that they're going to come?
Yep.
Okay.
Yep. They just call me and let me know, and I'll save a spot for them.
Awesome, Trisha. Well, thank you so much.
Thank you. I really appreciate it.
Yeah, me too. All right. Have a great day.
You too.